Lowering your blood pressure is one of the single most powerful ways to cut your risk of the leading cause of death in the Western world, heart attacks and strokes, and it's more powerful than people realise. If you've been told that lowering your blood pressure means cutting out salt and eating bland foods for the rest of your life, then I need you to know that that's not the full story. In fact, for most people, salt isn't even the main driver of high blood pressure, and I've made that point in a couple of videos already. Now, I know the whole salt debate sounds a bit controversial, but stick with me because what I'm about to share with you is going to completely change how you think about blood pressure control. And more importantly, I'm going to give you 14 practical, evidence-based strategies that actually work, some of which you can start using today, and others that might surprise you because they have nothing to do with what you eat at all. Hi, I'm Dr. Alex, and over the last 10 years working in the emergency department, I've become really focused on the patterns that I see repeating. The same conditions, the same complications, the same missed opportunities for prevention. And what I've realised is that high blood pressure, hypertension, is one of the most misunderstood conditions in modern medicine. And that really matters because cardiovascular disease remains the leading cause of death in the Western world, and high blood pressure is the single biggest driver of it. I see it all the time in most of the patients that I see. And for me, the reason it's one of the most misunderstood conditions is not because we don't know what causes it, but because the advice people receive is often oversimplified to the point where it becomes almost useless. I can't tell you how many times I've raised the issue of blood pressure with my own family, only for them to say, "But I don't eat salt." So I want to give you the insights I've gathered over the years, the physiological mechanisms that actually matter, and hopefully teach you something that, in this day and age, your doctor simply doesn't have time, or maybe even the education to explain. Because this stuff isn't really taught in medical school. We get taught how to prescribe you medication. And so in return, all I ask is that by the end of this video, if you've learned something valuable, then please subscribe to the channel, because it really does help this content reach more people who need it. Now, before we dive into the 14 strategies in a few minutes' time, we need to set the stage properly, because this isn't just about giving you a list of things to do. This is about understanding what blood pressure actually is and why the conventional wisdom has failed so many people. Blood pressure is essentially the force of blood pushing against the walls of your arteries as your heart pumps. And it's measured in two numbers. The first one is systolic pressure, which is the pressure when your heart beats. And then diastolic pressure, the number at the bottom, which is the pressure when your heart rests between beats. Normal pressure is generally considered to be around 120/80, though there is some debate about whether even lower is better for your long-term health. The problem is that when blood pressure stays consistently elevated, above 130/80 by current definitions, it puts enormous strain on your cardiovascular system. Your heart has to work harder to pump blood around the body. Your arteries become stiffer and less flexible. And over time, this leads to heart disease. It leads to strokes and kidney failure and a cascade of other complications. In the emergency department, I see the end result of this process almost every day. Strokes that leave people unable to speak or move, heart attacks in people who thought they were fine because they felt normal, kidney failure requiring dialysis. And the tragic part of all of that is that so much of this is preventable. And I'm seeing so much more of it in younger people these days. But here's where things get really interesting and where the conventional advice starts to fall apart. For decades, we've been told that salt is the primary dietary villain in high blood pressure. Reduce your sodium intake, the advice goes, and your blood pressure will come down. And while there is some truth to this for certain individuals, the reality is that for the majority of people, salt is not the main driver of their hypertension. In fact, large population studies have shown that the relationship between salt intake and blood pressure is far more complex and far less dramatic than we've been led to believe. A 2011 study published in the Journal of the American Medical Association followed over 3,000 people for more than 20 years and found that those who consumed the least amount of salt actually had higher cardiovascular mortality than those who consumed moderate amounts. Now, this doesn't mean that you should start pouring salt on everything. But it does mean we need to stop treating salt as the singular enemy and start looking at the bigger picture. Because blood pressure isn't controlled by one nutrient or one dietary choice. It's controlled by how your metabolism functions, how healthy your blood vessels are, how your nervous system is balanced, and how your daily habits, from when you eat to how much you move, how you sleep, all interact with each other. What I'm going to tell you today are 14 evidence-based strategies that address these underlying mechanisms. Some of them you'll be familiar with, like exercise and alcohol reduction. Others might surprise you, like the timing of your caffeine intake or the importance of breathing patterns. But each one is backed by research, and each one works through a specific physiological pathway that actually matters for blood pressure control. These 14 points aren't everything, but they are a selection of the most common things that I've seen over the years. And just before we start, I just want to mention that these aren't the only things that lower your blood pressure. There are other big levers that I've covered in other videos and things that I'll cover in future videos. What I'm sharing today is a deliberately chosen set of patterns that I see again and again. Practical, evidence-based changes that are relatively easy to implement and that reliably move the needle for most people. And that's why I've included them in this video. So, first on our list, and this is something that doesn't get nearly enough attention in mainstream blood pressure advice, and that is consuming flavonoid-rich foods. Now, when I say flavonoids, I'm talking about a group of plant compounds found in foods like dark chocolate, berries, tea, both green tea and black tea, and then certain fruits like apples and citrus. These compounds have a remarkable ability to improve what we call endothelial function, which is essentially how well the inner lining of your blood vessels work. The endothelium is this really important inner layer of your blood vessels. It's not just a passive barrier, it's an active organ that produces nitric oxide, a molecule that tells your blood vessels to relax and dilate. When your endothelium is healthy and producing adequate nitric oxide, your blood vessels stay flexible and responsive, your blood pressure stays lower, and your cardiovascular system functions more efficiently. But when endothelial function is impaired, which happens with aging, with insulin resistance, with inflammation and oxidative stress, your blood vessels become stiffer, less responsive, and your blood pressure can creep up. What flavonoids do is improve the availability of nitric oxide in your blood vessels. They do this through multiple mechanisms. They reduce oxidative stress that would otherwise destroy nitric oxide. They improve the function of the enzyme that produces nitric oxide, and they reduce inflammation in the blood vessel wall. A meta-analysis published in the American Journal of Clinical Nutrition looked at 23 randomized controlled trials, and it found that cocoa flavonoids, the kind found in really dark chocolate, reduced systolic blood pressure by an average of 3.2 millimeters of mercury and diastolic pressure by 2. Now, that might not seem like a massive reduction, but on a population level, even a reduction of 2 in your systolic blood pressure could prevent tens of thousands of cardiovascular events each year. What's really interesting about this research is that blood pressure reduction was most pronounced in people who started with higher baseline blood pressure. In other words, if your blood pressure is already somewhat elevated, the effect of flavonoid-rich foods appears to be even stronger. And this makes sense physiologically because people with higher blood pressure typically have worse endothelial function and more oxidative stress, so they have more room for improvement. The practical takeaway here is that incorporating flavonoid-rich foods into your daily diet is a really simple and enjoyable strategy that works through a fundamental mechanism, improving your vascular biology. I'm not talking about eating chocolate bars loaded with sugar, but rather quality dark chocolate with at least 70% cocoa content. Or better yet, a variety of berries, regular tea consumption, and other plant foods rich in these compounds. The key is consistency rather than occasional indulgence, because the improvements in endothelial function accumulate over time with regular intake. Moving on to our second strategy, and this is one where I see deficiency far more often than people realise. we need to talk about magnesium. So magnesium is involved in over 300 enzymatic reactions in your body, and one of its most important roles is regulating vascular smooth muscle tone, essentially how tight or relaxed the muscular walls of your blood vessels are. When you don't have enough magnesium, your blood vessels tend to constrict more easily, which directly raises your blood pressure. The mechanism here actually is really fascinating because magnesium acts as a natural calcium antagonist. Now, calcium is essential for muscle contraction, including the smooth muscle cells of your blood vessel walls. But too much calcium activity in these cells causes excessive constriction and stiffness. Magnesium counterbalances this by blocking calcium channels and promoting relaxation. It's the same principle behind calcium channel blocker medications used to treat high blood pressure, like amlodipine, except magnesium is a nutrient that your body needs anyway for hundreds of other functions. The problem is that magnesium deficiency is incredibly common in modern populations. A 2012 study published in Nutrition Reviews estimated that nearly 50% of Americans consume less than the recommended amount of magnesium from their diet. 50% is huge. And this deficiency often goes unnoticed because routine blood tests don't accurately reflect magnesium status. Most of your body's magnesium is stored in bone and soft tissue, not in your bloodstream. So you can have normal blood magnesium levels, but still be functionally deficient at the cellular level where it actually matters. Now, research on magnesium supplementation and blood pressure is quite compelling. A meta-analysis published in the American Journal of Hypertension in 2012 reviewed 22 different trials involving over 1,000 participants and found that magnesium supplementation produced an average reduction of 3 to 4 millimeters of mercury in systolic blood pressure and 2 to 3 millimeters of mercury in diastolic pressure. Similar to flavonoids, the effect was more pronounced in people who were likely deficient to begin with and in those with higher baseline blood pressure. Now, beyond blood pressure control, magnesium deficiency is also strongly associated with insulin resistance, which, as we'll discuss later, is a major driver of hypertension. Low magnesium impairs the insulin signaling pathway, making your cells less responsive to insulin, which leads to higher circulating insulin levels in your blood. These higher levels of insulin then contribute to higher blood pressure through lots of different mechanisms that we'll explore later in the video. So how do you actually ensure adequate magnesium intake? Well, dietary sources include leafy green veg like spinach and kale, nuts and seeds, particularly pumpkin seeds and almonds, legumes, whole grains, dark chocolate, another reason to include dark chocolate we mentioned earlier. Now, for many people, especially those with high requirements due to stress, due to exercise or poor absorption, supplementation can be beneficial. Magnesium glycinate is generally well tolerated and well absorbed, with typical doses ranging from 200 to 400 milligrams daily. The point is that optimizing magnesium status is a fundamental step in blood pressure management that addresses a basic biochemical requirement for vascular health. Moving on to caffeine. So number 3 on our list is going to surprise a lot of people because it's not about whether you consume caffeine, but when you consume it. I see so many patients who've been told to cut out coffee entirely because of their blood pressure, and they're miserable about it. I would be, because they genuinely enjoy their morning coffee. The good news is that for most people, caffeine itself isn't actually the problem. The problem is late caffeine consumption and how it affects your blood pressure patterns throughout the 24-hour cycle. Your blood pressure naturally follows a circadian rhythm. During your sleep, your blood pressure should drop by about 10 to 20% compared to daytime levels, a phenomenon we call nocturnal dipping. This overnight reduction is incredibly important for cardiovascular health because it gives your heart and blood vessels a chance to recover from the demands of the day. People who don't experience this normal dip, called non-dippers, have significantly higher rates of cardiovascular events, even if their daytime blood pressure readings look normal. What researchers discovered through ambulatory blood pressure monitoring, where people wear a device that measures their blood pressure every 20 or 30 minutes throughout the day, is that late caffeine consumption, typically defined as caffeine intake after 2 or 3 p.m., significantly elevates nocturnal blood pressure and reduces or eliminates the healthy overnight dip. A study published in the Journal of Clinical Sleep Medicine found that caffeine consumed even 6 hours before bedtime significantly disrupted sleep architecture and raised blood pressure during sleep, even though the participants didn't subjectively feel that their sleep was affected. The mechanism involves caffeine's effect on the sympathetic nervous system, which is your body's fight or flight response system. Caffeine blocks adenosine receptors, which normally promotes relaxation and sleep. This blockade increases sympathetic nervous system activity. It raises cortisol levels and maintains higher blood pressure when it should naturally be falling. As well as this, caffeine's half-life is around 5 to 6 hours in most of us, meaning that if you drink your coffee at 4 p.m., half of that caffeine is still circulating in your system at 10 p.m., which is when you're trying to wind down and go to sleep. The practical implication is that you can likely continue enjoying your morning coffee without guilt, but you should really establish a caffeine cutoff time that allows your body to clear most of it before the evening. For most people, and this has really worked for me, stopping caffeine intake by early afternoon, around 1 or 2 p.m. at the latest, preserves the normal nocturnal blood pressure dip without requiring complete caffeine elimination. This is a perfect example of how timing can be just as important as the substance itself, and it's a much more sustainable approach than telling people to give up something they enjoy when the real issue is simply when they're consuming it. The fourth strategy we need to discuss is reducing prolonged sitting. And this one matters even if you exercise regularly. I've seen this pattern repeatedly with patients who think they're doing everything right. They go to the gym for an hour in the morning, they eat reasonably well, they're not overweight, but their blood pressure is still elevated. When we dig into their daily routine, what we often find is that they are sitting for 8, 9, 10 hours a day, mostly at work. And that prolonged, uninterrupted sitting is sabotaging their blood pressure control despite their exercise efforts. The physiology here is really important to understand. When you sit for extended periods, blood flow through your arteries decreases significantly, particularly in your legs. This reduced blood flow decreases what's called shear stress, the frictional force of blood flowing against the artery wall. Now, shear stress, SHEAR, is actually a good thing because it stimulates the endothelial cells we discussed earlier to produce nitric oxide, which, as we mentioned, keeps blood vessels relaxed and flexible. When you eliminate that shear stress by sitting still, nitric oxide production stops, vascular tone increases, and blood pressure rises. Now, a landmark study published in 2015 examined what happened when healthy adults sat continuously for 3 hours, compared to when they interrupted that sitting with brief 2-minute walks every 20 minutes or so. And the results were really striking. What they found was that continuous sitting caused progressive increases in blood pressure throughout that 3 hours, while the interrupted sitting group maintained stable blood pressure throughout the study period. The researchers measured endothelial function using a technique called flow-mediated dilation and found that the continuous sitting group showed significant impairment, while the interrupted sitting group maintained normal endothelial function. What makes this particularly relevant for modern life is that many of us have jobs that require extensive sitting. Desk workers, drivers, people in meetings all day. Even if you're committed to your evening workouts, that 1 hour of exercise doesn't fully compensate for 8 hours of uninterrupted sitting. The metabolic and vascular effects of prolonged sitting appear to be somewhat independent of your overall fitness level. So the solution doesn't require dramatic changes or fancy equipment. Setting a timer to stand and move, even just for 2 minutes every half an hour, can make a measurable difference. This could be walking to get water, doing a few stretches, doing a few squats like I do, walking up and down the stairs, or even just standing and shifting your weight. Some people use standing desks or a treadmill desk for part of their workday. The principle here is breaking up long periods of sitting rather than achieving any particular exercise intensity. We know that research shows that these brief interruptions throughout the day improve your insulin sensitivity, it reduces your blood pressure, and it maintains vascular function in ways that just a single workout doesn't fully replicate. Coming on to our fifth strategy, and this is where we start to see how deeply blood pressure is connected to metabolic health. We need to talk about time-restricted eating, specifically eating in an earlier window during the day rather than eating late into the evening. This isn't about what you eat or even necessarily how much you eat, but rather aligning your eating patterns with your body's natural circadian rhythms, and the blood pressure effects are quite remarkable here. Your body doesn't process food the same way at all times of the day. Insulin sensitivity, your cell's ability to respond to insulin and take up glucose from the bloodstream, follows a circadian pattern. You're most insulin sensitive in the morning and progressively less sensitive as the day goes on. And what this means is that the same meal eaten at 8 a.m. will produce a smaller insulin response than if that meal was eaten at 8 p.m., even though the food is identical. This matters enormously for blood pressure because elevated insulin levels, particularly in the evening and overnight, suppresses the normal nocturnal blood pressure dip that we discussed earlier. A study published in Cell Metabolism in 2019 compared two groups of men with metabolic syndrome. Both groups ate exactly the same total amount of food and the same macronutrient composition, but one group ate within a 6-hour window, finishing at 3 p.m., while the other group ate in a typical 12-hour window, extending late into the evening. After 5 weeks, the early time-restricted eating group showed significant reductions in blood pressure. On average, a reduction of 11 in their systolic blood pressure, even though they lost no weight. The control group, eating later into the evening, showed no improvement. Now, the researchers used ambulatory blood pressure monitoring to see what was happening throughout the 24-hour cycle, and they found that the early eating group restored their normal nocturnal blood pressure dipping. Their blood pressure dropped appropriately during sleep, while the late eating group maintained elevated blood pressure throughout the night, when it should be much lower. This restoration of normal circadian blood pressure patterns happened without any change in body weight, showing that the effect was metabolic and circadian rather than simply about their weight loss. Now, the mechanism here seems to involve multiple factors. Evening eating keeps insulin levels elevated when they should be falling. And as we'll discuss later, insulin causes the kidneys to retain sodium and activates the sympathetic nervous system. As well as this, eating late disrupts sleep quality by keeping your digestive system active and maintaining higher core body temperature when it should be falling. Poor sleep then further impairs insulin sensitivity and raises blood pressure in a more vicious cycle. The practical application doesn't mean you need to stop eating at 3 p.m. like the research study. That's quite extreme for most people's lifestyle, but it does suggest that finishing your last meal by early evening, say 7 or 8, or even earlier if you can, and then having a 12 to 14 hour overnight fast before breakfast can have a meaningful blood pressure benefit. For someone eating breakfast at 7 a.m. and then finishing dinner by 7 p.m., that's a 12-hour eating window and a 12-hour fasting window, which is achievable for most people and still provides these circadian metabolic benefits. The key insight here is that when you eat matters, not just what you eat, and timing your food intake earlier in the day aligns with your physiology rather than fighting against it. Moving on to number 6, which is one of the simplest and most underestimated interventions for blood pressure control, and it's something that you can literally start doing after your next meal today. I'm talking about walking, particularly walking after meals. The consistency of research showing blood pressure benefits from regular walking is remarkable. It's undeniable. And when you walk specifically after eating, you get additional metabolic advantages that compound the effect. Walking affects your blood pressure through several different mechanisms. The most obvious one is that physical activity increases blood flow and shear stress throughout your arterial system, which, as we discussed earlier, stimulates nitric oxide production and improves endothelial function. But walking also has immediate effects on the autonomic nervous system. The balance between your sympathetic, which is your fight or flight response, and your parasympathetic nervous system, which is rest and digest. Regular walking shifts this balance towards greater parasympathetic activity and lower sympathetic tone, which directly lowers your blood pressure over time. There was a huge meta-analysis published in the British Journal of Sports Medicine in 2013, and it reviewed 27 randomized controlled trials examining walking programs and blood pressure. The researchers found that walking programs consistently reduced systolic blood pressure by an average of 4.1 and diastolic blood pressure by 1.8. What's really interesting is that these reductions occurred across different walking intensities and durations, suggesting that the key factor was consistency of the habits rather than achieving any particular exercise intensity or heart rate zone. When you walk, specifically after meals, you add another layer of benefit related to glucose metabolism and insulin sensitivity. After you eat, particularly a meal containing carbs, your blood glucose rises and your pancreas secretes insulin to help your cells absorb that glucose. Walking during this post-meal period helps your muscles take up glucose without requiring as much insulin, effectively making your body more insulin sensitive. A study published in 2016 found that 3 short 15-minute walks after meals were more effective at improving blood glucose control than a single 45-minute walk at another time of the day, even though the total exercise time was the same. 3 15-minute walks were better than a single 45-minute walk. And this improved glucose handling and reduced insulin response matters for blood pressure because, as we keep touching on, elevated insulin is a direct driver of blood pressure elevation through lots of different ways. Insulin increases sodium retention in the kidneys, which expands blood volume. It activates the sympathetic nervous system, which increases your heart rate and your vascular tone. And chronically elevated insulin promotes vascular remodeling that makes arteries stiffer and less compliant. By walking after meals and by blunting that insulin response, you're preventing these blood pressure raising effects from occurring with each meal. The beauty of post-meal walking is that it's achievable for almost anyone, regardless of your fitness level. We're not talking about intense exercise. Just a gentle 10 to 15 minute walk at a comfortable pace is enough to produce these benefits. You don't need to change clothes or go to a gym or even put your walking boots on. After lunch at work, walk around the building or the block. After dinner at home, walk around your block or walk up and down the stairs. The habit is more important than the intensity, and because you're anchoring the walk to meals which happen regularly throughout the day, it becomes a reliable pattern rather than something that you have to find motivation for each time. Now, our 7th strategy shifts our focus to a different type of exercise that many people don't associate with blood pressure control, and that is strength training or resistance training. There's a persistent misconception that only cardiovascular exercise like running or cycling helps with blood pressure, and that lifting weights might even be dangerous if your blood pressure is elevated. But the research tells a completely different story. Resistance training, which includes exercises like lifting weights or using resistance bands or bodyweight exercises like push-ups or squats, produces long-term reductions in resting blood pressure through mechanisms that are somewhat different from aerobic exercise. One of the most important mechanisms is the improvement in insulin sensitivity that occurs when you build and maintain muscle mass. Skeletal muscle is the primary site of glucose disposal in your body. When insulin signals to your cells to take up glucose from the bloodstream, most of that glucose goes into muscle tissue where it's either used for energy or stored as glycogen. As we lose muscle mass with aging, called sarcopenia, or even inactivity, we lose this glucose disposal capacity, which means that we have to produce more insulin to achieve the same glucose control. This hyperinsulinemia then drives blood pressure elevation through all of the mechanisms that we've discussed. By maintaining or building muscle mass through resistance training, you preserve or improve this glucose disposal capacity, which keeps insulin levels lower and reduces the insulin-driven component of hypertension. A meta-analysis published in Hypertension in 2016 reviewed 64 randomized controlled trials, which examined resistance training and blood pressure in over 2,000 participants. What the researchers found was that this resistance training reduced people's systolic blood pressure by an average of 3.2 and their diastolic blood pressure by 3.5. These reductions were independent of body weight changes or eating habits, showing that the effect wasn't simply about weight loss, but rather about the direct metabolic and vascular effect of the resistance training itself. What's really interesting is that the blood pressure reductions occurred across different training volumes and intensities. You don't need to become a power lifter or spend hours in the gym. Just 2 to 3 resistance training sessions per week, working major muscle groups like your chest, your back, and your legs and your glutes, appears to be sufficient for blood pressure benefits. This could be as simple as a 30-minute session focusing on compound movements like squats or deadlifts or presses and rows. Or it could be bodyweight circuit training at home or even at the gym. The critical factor here is progressive overload, challenging your muscles enough to stimulate adaptation and growth and consistency over time. Beyond insulin sensitivity, resistance training also reduces your sympathetic nervous system activity at rest. In the immediate period after resistance training, your blood pressure actually rises. This is completely normal and not dangerous for healthy individuals, but over weeks and months of regular training, your baseline sympathetic tone decreases and your resting blood pressure falls as a result. Your body essentially becomes more efficient and doesn't need to maintain as high a state of readiness. The practical message here is that resistance training isn't optional or only for people trying to build muscle for aesthetic reasons. It really is a fundamental component of metabolic health and blood pressure management, and therefore aging in general. For people who've been told to avoid lifting weights because of blood pressure concerns, then the evidence shows the opposite. Regular resistance training, performed with proper technique and appropriate loads, and under supervision if needed, is safe and beneficial for blood pressure control. The key is starting appropriately for your current fitness level and progressing very gradually, rather than just jumping into intense training that your body isn't prepared for. Moving on to number 8, and this is where we really start to dismantle the whole simplistic salt narrative. We need to talk about ultra-processed foods. The standard advice for blood pressure is to reduce your sodium intake, and the primary way people do this is by avoiding added salt and checking sodium content on food labels. And even when sodium is matched, these foods raise blood pressure through completely different mechanisms. Ultra-processed foods, things like packaged snacks, sugary drinks, instant noodles, sliced white bread, processed meats, packaged pastries, anything that's in a packet essentially. All of these have been systematically engineered to be hyperpalatable and to override your natural fullness signals. They're typically very high in refined carbohydrates and added sugars. They contain industrial seed oils, high in omega-6 fatty acids, and they have various additives and preservatives and emulsifiers. And they're designed to be consumed really quickly without much chewing. The combination of these factors creates this metabolic environment that promotes inflammation, oxidative stress, and insulin resistance, all of which, as we know, directly raise your blood pressure. There was a landmark study published in Cell Metabolism in 2019, which brought 20 adults into a metabolic ward where every aspect of their diet could be controlled. For 2 weeks, they ate an ultra-processed diet, and for another 2 weeks, they ate an unprocessed diet. The researchers carefully matched the diets for sodium content, sugar content, fiber, and macronutrients. The only difference was the degree of processing. And guess what the results were? On the ultra-processed diet, participants spontaneously ate more calories, they gained weight, and they showed markers of increased inflammation and oxidative stress. When they switched to the unprocessed diet, all of these parameters improved. Although this particular study doesn't measure blood pressure as the primary outcome, numerous other studies have examined the relationship between ultra-processed food and blood pressure. A large prospective cohort study published in the American Journal of Hypertension just a few years ago followed over 14,000 adults and found that those with the highest consumption of ultra-processed foods had significantly higher rates of developing hypertension over the follow-up period, even after adjusting for sodium intake, body weight, and other dietary factors. The mechanisms here are multiple and they're interconnected. We know that ultra-processed foods cause rapid spikes in blood glucose and insulin. This post-meal hyperinsulinemia, repeated multiple times per day with each eating occasion, chronically activates insulin's effects on sodium retention and sympathetic nervous system stimulation. The refined carbohydrates and industrial seed oils in these foods promote inflammation in the blood vessel walls, which impairs the endothelial function and reduces nitric oxide availability. The lack of fiber means rapid nutrient absorption and large metabolic swings rather than the gradual, modulated nutrient delivery that you get from whole foods. And as well as all of that, ultra-processed foods often displace nutrient-dense whole foods from the diet, meaning that people eating these foods are not only getting harmful components, but also missing out on the beneficial nutrients like magnesium and potassium and fiber and antioxidants that support healthy blood pressure. It's both what these foods contain and what they're replacing that matters. The practical takeaway is that focusing primarily on sodium reduction while continuing to eat a diet based on ultra-processed foods misses the point entirely. You could potentially reduce your sodium by choosing lower sodium processed options, but then you're still left with all of the other blood pressure raising mechanisms that these foods activate. A more effective approach is to base your diet primarily on whole foods or minimally processed foods. It's the obvious stuff and it's difficult, but it's things like veg, fruits, whole grains, legumes, nuts, seeds, fish, eggs, unprocessed meat, all of which naturally tend to be lower in sodium anyway, but more importantly, don't trigger the inflammatory and metabolic dysfunction that drives blood pressure elevation. This isn't about perfection or never eating anything processed. Instead, it's about making whole foods the foundation and treating processed foods as the exception rather than the rule. And all of that leads directly into number 9. And this brings us to what I consider one of the most important and most under-recognized drivers of high blood pressure in modern populations: poor insulin sensitivity, also called insulin resistance. We've mentioned insulin several times already when discussing the other strategies, and that's because insulin is absolutely central to blood pressure regulation. Many people can have completely normal fasting blood glucose. Their doctor runs standard tests and tells them that their blood sugar is absolutely fine, but they can still be significantly insulin resistant, and that insulin resistance is driving their blood pressure up. To understand this, we need to clarify what insulin resistance actually means. When you're eating, particularly carbohydrates, your blood glucose rises and your pancreas secretes insulin to signal to your cells to take up that glucose. In a healthy, insulin-sensitive state, your cells respond efficiently to insulin. Glucose is cleared from your bloodstream quickly and your insulin levels return to baseline. But when cells become resistant to insulin, your pancreas has to produce more and more insulin to achieve the same glucose control. You end up with chronically elevated insulin levels, hyperinsulinemia, which I mentioned earlier, even though your glucose might look normal on testing. This hyperinsulinemia has profound effects on your blood pressure regulation. The first thing is that insulin directly affects the kidneys by increasing sodium reabsorption in the tubules. Normally, your kidneys filter sodium and excrete the excess, but elevated insulin signals to your kidneys to hold on to sodium. This increases your blood volume, which directly raises your blood pressure through basic physics. More volume in the same container means higher pressure. The second thing is that insulin activates the sympathetic nervous system, which increases the release of noradrenaline and other catecholamines that increases your heart rate, your cardiac output, and your vascular tone. The third thing is that chronically elevated insulin promotes vascular smooth muscle cell proliferation and arterial stiffening, literally changing the structure of your blood vessels over time to make them less compliant and more resistant to blood flow. A comprehensive review published in the Journal of the American College of Cardiology examined this relationship between insulin resistance and cardiovascular disease, including hypertension. The authors documented that insulin resistance typically precedes the development of hypertension by several years, and that improving insulin sensitivity can lower blood pressure even in the absence of weight loss. This is a critical point. You don't have to lose weight first to improve your insulin sensitivity and lower your blood pressure. The metabolic improvements can occur relatively quickly with the right interventions. The challenge here is that standard medical testing doesn't usually assess insulin resistance adequately. Most doctors check your fasting glucose and maybe your HbA1c, but they don't check insulin levels or perform more sophisticated tests like oral glucose tolerance tests with insulin measurements. So many people are walking around with significant insulin resistance that's driving their blood pressure up, but it's completely invisible on standard testing. The clues are often quite indirect. Elevated triglycerides, low HDL cholesterol, a high triglyceride to HDL ratio, fatty liver, central obesity, but the insulin resistance itself isn't directly measured or addressed. Now, the interventions that improve insulin sensitivity overlap with all of the other strategies that we've discussed. There are common threads here. Reducing ultra-processed foods and refined carbs lowers the insulin demand on your system. Time-restricted eating and eating earlier in the day aligns with your natural circadian insulin sensitivity patterns. Walking after meals and resistance training both dramatically improve how your muscles respond to insulin. Adequate magnesium supports the insulin signaling pathway at the cellular level. These aren't separate strategies. They are all working on the same fundamental problem from different angles. For some people, particularly those with significant metabolic dysfunction or polycystic ovarian syndrome, medications like metformin that improve insulin sensitivity can be helpful for blood pressure control, but they're not for everyone. For most people, the lifestyle strategies that we've discussed are remarkably effective and much better for you when implemented consistently. The key insight is that blood pressure isn't just a cardiovascular problem. It's intimately connected to your metabolic health, and addressing insulin resistance is often the missing piece that makes everything work better. The 10th strategy on our list involves reducing alcohol consumption. And I want to be very careful here because the recommendations around alcohol have become quite nuanced in recent years. There was a time when moderate alcohol consumption, particularly red wine, was thought to be beneficial for cardiovascular health. The most recent evidence suggests that even modest alcohol intake, levels that most people would consider completely reasonable, has measurable effects on blood pressure that aren't necessarily benign. Alcohol affects your blood pressure through multiple different pathways. Acutely, alcohol consumption raises your cortisol levels and activates the sympathetic nervous system. In the immediate aftermath of drinking, you see increases in your heart rate, in your blood pressure, and your stress hormone levels. For someone having a drink or two with dinner, this might seem insignificant. But when this pattern repeats regularly, these acute spikes can translate into sustained elevation in baseline blood pressure. As well as that, alcohol significantly disrupts your sleep architecture, particularly the quality of your deep sleep and REM or REM sleep. Even when people don't feel like alcohol has affected their sleep, they fell asleep fine and slept through the night, objective measurements show that sleep quality is almost always impaired. This sleep disruption then affects your blood pressure regulation in other multiple ways. Poor sleep increases sympathetic nervous system activity, it raises your cortisol, it impairs insulin sensitivity, and disrupts the normal nocturnal pressure dipping that we keep coming back to. And that is critical for cardiovascular health. The dose-response relationship between alcohol and blood pressure has also been well established through multiple large meta-analyses. A particularly comprehensive analysis published in the journal Hypertension a few years ago reviewed over 20 studies involving more than 35,000 participants. What it found was a clear linear relationship between blood pressure and alcohol consumption. For every standard drink per day, systolic blood pressure increased by an average of 1.2 millimeters of mercury. Now, yes, that might not sound like much for a single drink, but if you're someone who consumes 2 or 3 drinks per day, which many people wouldn't even consider unhealthy, that's a 2 to 4 millimeters of mercury increase in your blood pressure that's completely preventable. What's really important from this research is that reducing alcohol intake lowered your blood pressure in a dose-dependent manner. It wasn't an all-or-nothing effect where only people who quit completely saw the benefits. People who reduced from 3 drinks per day to 1 drink per day saw meaningful blood pressure reductions. This is important because complete abstinence isn't realistic or even desired for everyone, but moderation and reduction are achievable goals. The challenge here, particularly in the UK and the US, is that alcohol consumption is deeply embedded in social and cultural contexts. People use alcohol to relax, to socialize, to celebrate, to cope with stress. So telling someone to reduce alcohol without addressing these functions and providing alternatives often doesn't work. The approach that seems most effective here is helping people become more aware of how much they're actually drinking, because most people significantly underestimate this, and then making conscious decisions about when and how much they drink based on their health priorities. For someone with elevated blood pressure, the evidence suggests that limiting alcohol to no more than 1 drink per day for women and 2 drinks per day for men is a reasonable guideline, and that having several alcohol-free days within each week is beneficial. For people drinking more than this, particularly those drinking daily, reducing intake is likely to produce measurable blood pressure benefits within weeks. The key is that alcohol isn't neutral. It's actively raising blood pressure through multiple different ways, and reduction or elimination is a powerful lever that is entirely within your control. And the final thing I'd say here is that there are lots of studies that you can point to that say that any amount of alcohol is bad for you, and that's something to consider. So let's move on to number 11. And this is where we tie together several threads that we've been developing throughout this discussion. We need to talk explicitly about restoring normal blood pressure dipping at night. I mentioned earlier that blood pressure should naturally drop by about 10 to 20% during sleep compared to daytime levels. This isn't just a curious physiological observation. It's a critical protective mechanism, and people whose blood pressure doesn't drop at night have dramatically higher rates of heart attack, stroke, kidney disease, and just overall mortality. The technical term for this pattern is non-dipping, as we mentioned in the caffeine section earlier, and is far more common than most people realise. Studies using 24-hour blood pressure monitoring estimate that anywhere from 25 to 40% of people with hypertension are non-dippers. What's really concerning is that these people can have office blood pressure readings that look reasonably controlled. When they go to the doctor, their blood pressure is normal, either because they naturally have lower daytime pressures or because medication is controlling their daytime pressure, but their nighttime pressure remains elevated and is silently damaging their cardiovascular system. The mechanism that normally produces your nocturnal blood pressure dipping involves multiple systems. Your sympathetic nervous system activity should decrease during sleep, and your parasympathetic activity should increase. And various hormones, including renin, angiotensin, and aldosterone that regulate blood pressure, should follow circadian patterns with lower levels at night. When any of these systems are dysregulated, the normal dipping pattern is disrupted. There was a landmark study published in Circulation in 2008, following 5,000 participants for more than 8 years, and it compared cardiovascular outcomes between dippers and non-dippers. The results were quite shocking. Non-dippers had more than twice the risk of cardiovascular death compared to dippers, even after adjusting for average 24-hour blood pressure levels, for age, for sex, and other risk factors. In other words, it wasn't just about whether their blood pressure was high, it was about the pattern of blood pressure throughout the 24-hour cycle. What's remarkable about this is that many of the causes of non-dipping are modifiable and directly addressed by strategies that we've already discussed. Sleep apnea, which we'll cover next, is one of the most common causes, and it's absolutely treatable. Late night caffeine consumption prevents this nocturnal blood pressure dipping throughout persistent sympathetic activation that we mentioned earlier. Evening eating, particularly high carbohydrate meals that cause significant insulin release, maintains elevated nighttime blood pressures. Poor sleep quality from any cause, alcohol, stress, irregular sleep schedules, blue light exposure before bed, all of these disrupts the autonomic nervous system balance that should produce the blood pressure dip. Insulin resistance and hyperinsulinemia suppresses nocturnal dipping through persistent sodium retention and sympathetic activation. The practical implication is that restoring normal nocturnal dipping isn't about adding a new intervention. It's about optimizing all of the factors that influence your blood pressure pattern throughout the 24-hour cycle. Stop caffeine early by afternoon, finish eating by early evening, manage your stress, and practice good sleep hygiene. Address your insulin resistance, get screened for sleep apnea if you're at risk. Each of these factors independently influence your nocturnal blood pressure. And when you address multiple factors altogether, the cumulative effect on your blood pressure can be dramatic. For people who are serious about their blood pressure, I often recommend 24-hour ambulatory blood pressure monitoring rather than relying solely on spot checks in the doctor's office or even on home blood pressure measurements taken during the day. What this does is it gives you a complete picture of what your blood pressure is doing throughout the entire circadian cycle, including during sleep, and it can reveal non-dipping that would otherwise be missed. Many cardiologists and GPs can arrange this monitoring, and some home monitoring devices now offer extended wear capabilities, though they're not quite as comprehensive as medical-grade ambulatory monitors. Let's move on to number 12, and this is one of the most common and under-recognized causes of treatment-resistant hypertension, and that's undiagnosed sleep apnea. I see this pattern constantly in the emergency department. People on 3 or 4 blood pressure medications, their pressures still aren't controlled. They're frustrated and worried, and when we dig deeper into their history, they are snoring loudly every night. Their partner says they stop breathing temporarily. They wake up gasping, and then they're tired all day despite spending 8 or 10 hours in bed. All of these are signs of sleep apnea. But remarkably, the condition often hasn't been formally diagnosed or treated. Sleep apnea involves repeated episodes of partial or complete airway obstruction during sleep. When your airway collapses, oxygen levels drop, obviously. Carbon dioxide builds up, and your brain has to briefly wake you up just enough to restore your breathing. These awakenings are so brief that you usually don't remember them happening, but they happen dozens or sometimes even hundreds of times per night in severe cases. Each episode triggers a massive surge in sympathetic nervous system activity, your body's emergency response to the situation of suffocation. Your heart rate spikes, your blood vessels constrict, your blood pressure shoots up as a result, and your stress hormones flood your system. Over time, this repeated nocturnal stress has several effects on your blood pressure. The first thing is that the sympathetic surges during each sleep apnea episode directly elevate your blood pressure during sleep, often to very, very high levels. Ambulatory monitoring in sleep apnea often shows blood pressure spiking to 180, 190, or even 200 during sleep apnea events. The second thing is that chronic sympathetic activation and oxidative stress from repeated hypoxia causes vascular remodeling and endothelial dysfunction, which raises your baseline blood pressure even when you're awake. The third thing is that sleep apnea disrupts your sleep quality and your normal circadian rhythm, which, as we've discussed, affects your blood pressure regulation through multiple different pathways. Now, the prevalence of sleep apnea in people with resistant hypertension, and what I mean by that is blood pressure that has remained uncontrolled despite being on 3 or 4 different medications, this is really, really high. Studies have found that 70 to 80% of people with resistant hypertension have sleep apnea. Yet the condition is massively underdiagnosed because people don't realise that their symptoms, which are snoring, fatigue, morning headaches, difficulty concentrating, nocturia, which is going to the toilet lots of times in the night, are related to a treatable sleep disorder. The good news is that treating sleep apnea with CPAP therapy, which is continuous positive airway pressure that keeps your airways open during sleep, can produce significant blood pressure reductions. Multiple randomized controlled trials have demonstrated this effect. A meta-analysis published in the Journal of the American Medical Association reviewed 29 trials and found that CPAP therapy reduced blood pressure by an average of 2.5 systolic and 2 diastolic. While these average reductions might seem quite modest, they mask significant individual variability. Some people have dramatic pressure reductions with CPAP, particularly those with more severe apnea and those who use the device consistently. What's really interesting is that the blood pressure reductions with CPAP are more pronounced during nighttime and morning hours, which makes sense given that that's when the apnea events are occurring. Some studies have even shown overnight blood pressure reductions of up to 10 millimeters of mercury or more with CPAP therapy. This reduction of normal nocturnal blood pressure patterns likely contributes significantly to the cardiovascular risk reduction seen with CPAP therapy in long-term studies. The practical message is that if you have hypertension, especially if your blood pressure is difficult to control, or if you have any symptoms suggestive of sleep apnea, then getting a sleep study is potentially one of the highest yield interventions available for you. The symptoms to look out for include loud snoring, witness breathing pauses during sleep, gasping or choking during sleep, excessive daytime sleepiness, morning headaches, difficulty concentrating, and the need to urinate multiple times during the night. Risk factors include obesity, male sex, older age, and anatomical features like a large neck circumference or a small jaw. Sleep studies can even now be done at home in many cases, which makes them much more accessible than they used to be when you had to go to a sleep lab and spend the night there. If sleep apnea is diagnosed and treated effectively with CPAP or other therapies like oral appliances or positional therapy, the blood pressure benefits often become apparent within weeks to months. For some people, this intervention alone can reduce the need for blood pressure medications or even eliminate the need for medication entirely. Moving on to number 13, and this is a more recent area of research that's generating a lot of interest. We need to talk about your gut microbiome and its influence on your blood pressure. The trillions of bacteria living in your digestive tract aren't just sitting there passively. They are actively producing compounds that affect your metabolism, your immune response, your vascular health, and yes, your blood pressure as well. The science here is still evolving, but the connections are strong enough that optimizing your gut health should be considered part of a comprehensive approach to your blood pressure management. The gut microbiome influences blood pressure through lots of different mechanisms. One of the most well-established pathways involves short-chain fatty acids that the gut bacteria produce when they ferment fiber. These short-chain fatty acids have wide-ranging effects throughout the body. They influence the production of hormones that regulate blood pressure. They have anti-inflammatory effects that improve endothelial function. They affect the sympathetic nervous system, and they influence how your kidneys handle sodium. A fascinating study published in Circulation Research in 2016 transplanted gut microbiota from hypertensive rats into normal rats and found that the recipient rats developed elevated blood pressure. The same researchers then showed that giving these rats acetate, one of the main short-chain fatty acids produced by gut microbacteria, lowered their blood pressure. This provided some of the first direct evidence that gut bacteria and their metabolic products can causally affect blood pressure regulation. In humans, several observational studies have found associations between gut microbiome diversity and blood pressure. Generally, people with more diverse gut microbiomes, meaning they have a wider variety of different bacterial species, tend to have lower blood pressure and their metabolic health is just better overall. A study published in Hypertension 6 years ago examined the gut microbiome composition in over 900 people and found that certain bacterial species were consistently associated with a lower blood pressure, while others were associated with higher blood pressure. The bacteria associated with lower blood pressure were often those that produce more short-chain fatty acids. Now, the challenge is translating this knowledge into practical interventions. We can't yet prescribe specific bacterial strains with confidence that they'll lower blood pressure in most people. The research just isn't there yet, but we can take steps to support a healthy, diverse microbiome which is likely to have benefit for blood pressure along with many other aspects of health. The most important factor for gut microbiome health is fiber intake. Fiber is the primary fuel for beneficial gut bacteria. Most modern diets are dramatically low in fiber. The average American consumes about 15 grams of fiber per day, when recommendations are 25 to 35 grams per day or more. Increasing your fiber intake from a variety of plant sources, which are veg, fruits, whole grains, legumes, nuts and seeds, provides fuel for a diverse population of gut bacteria and increases your short-chain fatty acid production. Beyond fiber, fermented foods may also support your gut health. Foods like yogurt, kefir, sauerkraut, kombucha and kimchi contain live bacteria that can transiently populate the gut and potentially influence the resident microbiome. While the evidence for blood pressure benefits specifically from fermented foods is still quite limited, these foods are just part of traditional diets in many cultures with lower rates of hypertension. As well as that, factors that harm your gut microbiome diversity should be minimized where possible. These include unnecessary antibiotic use. Yes, antibiotics are necessary and they are life-saving when needed, but they should be used very carefully because they devastate your gut bacterial populations. Other things like excessive consumption of artificial sweeteners, which some research suggests may negatively affect your gut bacteria. Very high intake of emulsifiers and other food additives common in ultra-processed foods, and potentially even chronic psychological stress, which has been shown to alter your gut microbiome composition. The practical takeaway is that supporting gut health through a fiber-rich, plant-predominant diet with some fermented foods and minimal levels of ultra-processed food intake is likely beneficial for blood pressure through microbiome mechanisms, even as the specific details are still being worked out. This approach happens to align perfectly with dietary patterns that we know from decades of research support healthy blood pressure, which is that emphasizing whole plant foods naturally optimizes multiple pathways simultaneously. And coming to our 14th and final strategy, with this one, we need to talk about slow breathing. Now, I'm not talking about meditation or mindfulness or any particular spiritual practice, though those can certainly incorporate slow breathing. I'm talking about the specific physiological effect of breathing at a rate of 4 to 6 breaths per minute, which is much slower than the normal resting breathing rate of 12 to 20 breaths per minute. When you breathe slowly and deeply, engaging your diaphragm fully, you activate several physiological mechanisms that lower your blood pressure. The first one involves something called baroreflex sensitivity. Baroreceptors are specialized sensors in your carotid arteries and your aorta that detect changes in blood pressure and send signals to your brain to make adjustments. When blood pressure rises, baroreceptors signal to your brain to lower your heart rate and dilate your blood vessels. When blood pressure falls, they signal the opposite. This system acts as a moment-to-moment buffer against blood pressure fluctuations. The problem is that baroreflex sensitivity declines with aging, with chronic stress, and cardiovascular disease. People with hypertension often have impaired baroreflex function, meaning that their bodies don't respond as efficiently to changes in blood pressure. Slow breathing has been shown in multiple studies to improve baroreflex sensitivity over time. A study published in the American Journal of Hypertension in 2006 had participants practice slow breathing for 15 minutes daily, and it found significant improvements in baroreflex sensitivity along with blood pressure reductions after 8 weeks. The second mechanism involves the balance between sympathetic and parasympathetic nervous system activity. Slow breathing, particularly when you extend the exhale phase to be longer than the inhale, activates the vagus nerve and increases parasympathetic tone. This shifts your autonomic nervous system away from the fight or flight sympathetic dominance that characterizes stress and hypertension towards a more relaxed sympathetic state. This shift directly lowers your heart rate, it reduces your vascular resistance, and decreases your blood pressure. The evidence for slow breathing's effect on blood pressure is actually quite robust. A systematic review and meta-analysis published in the Journal of Human Hypertension in 2019 examined 17 randomized controlled trials involving over 1,000 people. The researchers found that device-guided slow breathing, or using devices that provide audio or visual cues to guide breathing patterns, reduced systolic blood pressure by an average of 5.6 and diastolic pressure by an average of 3.2. Now, these reductions are comparable to what you might see with a single blood pressure medication. What's really interesting is that some of the research has compared slow breathing directly to standard blood pressure medication. A study published in Hypertension in 2003 compared device-guided slow breathing to relaxation techniques and to blood pressure medication in people with hypertension. The slow breathing group achieved blood pressure reductions that were similar in magnitude to those seen in the medication group, and both were superior to just generic relaxation. The practical application doesn't require any special equipment, though some people do find breathing devices or apps on their phone helpful for maintaining the proper pace. The basic technique is to sit comfortably. Breathe slowly through your nose, aiming for about 5 to 6 breaths per minute. This typically means inhaling for 5 to 6 seconds and exhaling for 5 to 6 seconds. The breathing should be diaphragmatic. Your belly should expand on the inhale, not just your chest. Practice this for 10 to 15 minutes daily, ideally at the same time each day, just to build a consistent habit. Now, some people find it helpful to practice this slow breathing routine in the evening as part of a wind down routine before bed, which has the added benefit of improving your sleep quality. Others prefer morning practice to set a calm tone for the day. The key is consistency rather than perfection. You do not need to hit exactly 5 breaths per minute or practice daily for 15 minutes. Even 5 to 10 minutes of slow breathing appears to produce benefits when done regularly. Now, what makes this intervention really valuable is that it's entirely free. It has no side effect. It can be done anywhere, and it provides immediate relaxation benefits, even as the blood pressure effects accumulate over time with consistent practice. For someone who's overwhelmed by all the dietary and lifestyle changes recommended for blood pressure, slow breathing offers a simple, achievable starting point that can produce measurable results while building confidence and momentum for other changes. So this has been a really long video, so well done for getting this far. We've covered 14 distinct strategies for lowering blood pressure naturally. And you might be wondering how to make sense of all this information and actually apply it in your own life. The most important thing to understand is that these aren't 14 separate interventions that you need to do perfectly. There are 14 different ways of addressing the same underlying problems of vascular dysfunction, metabolic dysregulation, autonomic imbalance, and chronic sympathetic activation. Blood pressure isn't controlled by one nutrient or one behavior. It's controlled by how your metabolism functions, how healthy your blood vessels are, how balanced your nervous system is, and how your daily habits throughout the 24-hour cycle support or undermine these symptoms. Salt is part of the picture for some people, but it's a small part of a much larger story. Now, the strategies that we've discussed work through overlapping mechanisms that all reinforce each other. When you eat earlier in the day and practice time-restricted eating, you improve insulin sensitivity. When you improve insulin sensitivity through diet timing, through exercise and reducing ultra-processed foods, you reduce the metabolic drivers of blood pressure elevation and restore normal nocturnal blood pressure dropping. When you stop caffeine by early afternoon, you finish eating by early evening, and you practice good sleep hygiene, you support your normal sleep architecture and circadian blood pressure patterns. When you maintain adequate magnesium, when you consume flavonoid-rich foods, when you break up prolonged sitting, and you practice slow breathing, you improve endothelial function and vascular flexibility. The practical approach is to start with the interventions that feel most achievable for your current situation and that address your biggest gaps. If you're currently sitting 8 hours straight at work, then prioritizing movement breaks might be your highest yield change. If you're drinking coffee at 4 p.m. every day and not sleeping well, then shifting your caffeine cutoff earlier in the day is probably more important than worrying about whether you're eating enough berries. If you're consuming ultra-processed foods at most meals, then focusing on incorporating more whole foods will improve multiple pathways at the same time. For most people, the changes that produce the biggest improvements are those that address insulin resistance and metabolic health. Time-restricted eating with an earlier eating window, reducing ultra-processed foods, walking after meals, and adding resistance training. These interventions improve the fundamental metabolic dysfunction that's driving blood pressure elevation in a large proportion of modern populations. If you layer that on top of the circadian and autonomic interventions, which are caffeine timing, alcohol moderation, sleep optimization, and stress management through slow breathing, then you've added most of the modifiable factors affecting blood pressure. Now, it's worth emphasizing that these strategies are supported by lots and lots of rigorous research. Everything we've discussed is based on randomized controlled trials, on meta-analyses and physiological mechanisms that are well understood. This isn't speculation or trends. It's evidence-based medicine applied to prevention and lifestyle intervention rather than pharmaceutical treatment. Now, that doesn't mean that medication isn't sometimes necessary or appropriate. For people with very high blood pressure, medication may be essential to prevent the immediate complications while lifestyle changes are implemented. For people with genetic factors or kidney disease driving the hypertension, medication may always be necessary. But even for people on medication, these lifestyle strategies often allow for lower medication doses, for fewer side effects, and better overall cardiovascular health. As I always say, the goal isn't perfection, it's progress and consistency. Each of these interventions, implemented consistently over time, produces measurable benefits. You don't need to do all 14 simultaneously. You don't need to be perfect with any single one. What matters is making sustainable changes that move you in the right direction and then building on those successes over time. I really hope this has given you a more complete understanding of what actually drives your blood pressure and what you can do about it beyond the simplistic advice just to cut salt. And if you found this valuable or you learned something from today, then please consider subscribing to the channel and giving this video a like, because it really does help this content reach more people who could benefit from this information. Thank you so much, and I'll see you in the next one.